Now I invite Dr. Sindhu, who is a consultant in critical care medicine, who has been experienced in Hyderabad National Hospital and Apollo Hospital.
Very good morning, everyone. Thanks to the Reflect team for giving me this opportunity. And we are going to discuss about ICU delirium for the next 15 minutes. What is delirium? The term delirium was derived from delirium, which is the most underdiagnosed form of delirium. In this, the patients are lethargic and stuporous, and mixed delirium, which is the most common form of delirium. In this, the patients can be hyperactive for some time and hypoactive for some time. And what are the risk factors for delirium in ICU? ICU patients are exposed to multiple risk factors that increase the risk of delirium, and they can be broadly classified into predisposing risk factors and precipitating risk factors. The predisposing risk factors are the factors which increase the vulnerability of the patient and that are present in the patient before the admission to the ICU. And the precipitating risk factors are the harmful triggers that precipitate delirium in the ICU. Both these factors interact, and more or stronger the predisposing factors are present and lesser the precipitating factors are required to trigger delirium and vice versa. Among the precipitating factors, they are again classified into acute illness related factors, environmental factors and medication related factors. So the drugs which are implicated in increasing the risk of delirium in ICU are benzodiazepines, anticholinergics, opioids and corticosteroids. These 4 drugs are to be avoided in ICU and to be given to the ICU patients only when required. So, then why delirium is of concern in ICU? In many of the studies showed that delirium is associated with increase in hospital mortality, longer hospital and ICU length of stay, increased risk of self-extubations, failed extubations, removal of catheters, agitation-related events, and development of post-ICU cognitive dysfunction. So, the SCCM PADIS guidelines recommended routine monitoring of delirium in all adult ICU patients using either CAM-ICU score or ICDSC screening checklist. The CAM-ICU score comprises of 4 components. The first component is assessment for acute change or fluctuating course of the mental status in a day, followed by assessing for inattention and then assessing for altered level of consciousness and questions and commands related to disorganized thinking. Then the ICDSC scale comprises of 8 components, and this checklist and 1 point will be given for each checklist item, and a total score of 0 to 8 will be given to the patient. A score of 0 represents no delirium, and a score of 1 to 3 indicates subsyndromal delirium, and a score from 4 to 8 indicates that the patient is having delirium. So, while diagnosing delirium, we should always look for symptoms and signs of delirium mimics. In typical cases, the diagnosis can be made without any imaging or neurophysiological investigations, but CT or MRI brain or EEG is indicated in patients who present with either new focal neurological signs or present with uncommon features that are not common to the delirium and that suggest a structural cause. So, several models are available for prediction of delirium in ICU. So, 2 of the validated scores are E-predeliric score and pre-deliric score. E-predeliric score is for early prediction of delirium, which comprises of 9 components, and it is done at the time of admission to the ICU. And pre-deliric score can be done after 24 hours of admission to the ICU, and it comprises of almost 10 components. Coming to the prevention and treatment of delirium, it was found that no single pharmacological agent can prevent or treat delirium in ICU. So it is necessary to actively monitor for delirium and pay attention to the details that may put the patient at risk for delirium. Many of the drugs were studied for treatment and prevention of delirium in ICU, and the 3 important drugs that were studied are typical And these two trials didn't show any significant mortality benefit in the duration of delirium and also in the duration of delirium when they are given compared to placebo. The study done with atypical antipsychotic ziprosidone comparing with haloperidol and placebo is the MIND USA trial that also showed no significant difference in the duration of delirium. So dexmedetomidine was one more drug that was extensively studied for sedation in case of ICU patients that are on mechanical ventilator, and this dexmedetomidine was also shown to be having no significant mortality benefit, but patients who received dexmedetomidine showed more ventilator-free days and accelerated resolution of delirium when it was given for sedation in mechanically ventilated patients. The other drugs that were studied are statins, propofol, ketamine, and melatonin receptor agonist Rametian. So this melatonin receptor agonist was under trials in recent times. In the study done by Nishikimi et al., they showed that giving the melatonin at around 8 milligrams per day at around 8 o'clock in the night showed that it statistically significantly decreased the duration of ICU stay and decreased the incidence and duration of delirium in critically ill adults. So as there are no drugs that can prevent and treat the delirium, the studies are now being conducted in targeting the risk factors for delirium and non-pharmacological interventions, which are multi-component interventions for the treatment of delirium. So non-pharmacological multi-component interventions that should focus on cognitive impairment, sedation and sleep impairment, immobility and hearing and visual impairments. And these can be the methods that were tried are reorientation to time, place and person in ICU patients, cognitive stimulation, music and usage of large clocks and calendars inside the ICU, reduction in the sedation usage, minimization of the noise, reduction in nighttime light and exposure to bright light and daylight, early mobilization, and encouraging the use of hearing aids and glasses in patients who have hearing and visual impairment. One such multi-component approach that is used in ICU and that has shown to significantly decrease the incidence of delirium and mortality is A to F bundle. This ABCDEF bundle comprises of 6 components, where A stands for assessing prevention and management of pain, and B uses both spontaneous breathing and spontaneous awakening trials for early liberation from mechanical ventilation, and C stands for understanding the importance of depth of sedation and analgesia and choosing a right choice for sedation and analgesia. D stands for assessing prevention and management of delirium. E is the early mobility and exercise and physiotherapy. F is family engagement and empowerment in patient care. This A to F bundle was studied extensively in almost 15,000 adults in a prospective multi-center cohort study, and they studied bundle performance in 2 ways, either complete bundle performance or proportional bundle performance, and they found that complete bundle performance showed significant and clinically meaningful improvements in duration of ICU stay and duration of mechanical ventilation, decreased incidence of delirium and coma, and restraint-free care, ICU readmissions, and post-ICU discharge predisposition. So, 2018 delirium Paris guidelines, the delirium statement was suggested that there is no pharmacological drug that can prevent delirium or that can be used to treat either delirium or subsyndromal delirium. These guidelines recommended to use dexmedetomidine for delirium treatment in mechanically ventilated patients in which agitation is precluding bleeding and extubation. Otherwise, they suggested not to use any of the drugs for treatment of delirium or subsyndromal delirium. And they focused on pharmacological interventions which should focus on multi-component non-pharmacological interventions, reducing the modifiable risk factors like improving the cognition, optimizing sleep, early mobility, and optimizing hearing and vision in critically ill adults. Coming to the review of recent literature that was done in the last couple of years, the Eurydice trial, which was published in Critical Care Medicine Journal, is a multi-center, double-blind, placebo-controlled trial done in 8 mixed medical and surgical ICU patients. In the included subjects are the critically ill adults with delirium. They received either haloperidol 2.5 mg eighth-hourly or placebo, and additional doses of 5 mg eighth-hourly was given if the delirium is persistent. And this drug was given till ICU discharge or up to the 14 days. The primary outcome that was studied is delirium and coma-free days in the ICU within first 14 days. And they found there is no significant difference in the primary outcome between the two groups. However, among the secondary outcomes, they found that usage of rescue medications, especially benzodiazepine usage, was significantly low in case of haloperidol group compared to placebo group. And among the agitation-related events, incidence of self-extubations and removal of invasive devices was found to be low in haloperidol group compared to placebo. One more study that was published in NEJM in 2022 is AID-ICU study, which compared haloperidol for the treatment of delirium in ICU patients compared to placebo. Haloperidol was given at a dose of 2.5 mg 3 times daily plus 2.5 mg additional doses were given as required at a maximum of 20 mg per day. It was compared with placebo. And the primary outcome that was studied is the number of days alive and out of hospital at 90 days, and they found that treatment with haloperidol did not lead to a significantly greater number of days alive and out of hospital at 90 days when compared to placebo. Another drug that was under being trialed is the melatonin receptor agonist tramadol, the ProMedic trial. In this, they gave indistinguishable liquid melatonin 4 milligrams or placebo enterally at around 9 o'clock in the night for 14 consecutive nights. The included trial subjects are ICU patients of more than 18 years of age and expected to stay in ICU for more than 72 hours. And the primary outcome that was studied is the proportion of delirium-free assessment as a marker of delirium prevalence within 14 days or before ICU discharge. They found that there is no significant difference in the primary outcome between the two groups. Among the secondary outcomes also, they found there is no significant difference between the two groups based on length of ICU stay, hospital stay, and mortality at any time in the ICU at 28 days and at 90 days. And they concluded that the findings of this study do not support the routine early use of melatonin in critical illness. Two more studies were published recently, which evaluated the non-pharmacological interventions for the management of delirium, the mobilization in the evening to prevent and treat delirium, mixed methods randomized controlled feasibility trial. In this trial, they studied the feasibility of doing evening mobilization. They compared it with usual care and along with the usual care plus evening mobilization from 7 to 9 p.m. in the evening for 7 consecutive evenings or till ICU discharge. The primary objective to assess was to assess the feasibility and acceptability of evening mobilization, and they demonstrated a good feasibility and acceptability of both the trial design and evening mobilization intervention. And the qualitative analysis also demonstrated good acceptability reported by both participants and the staff. And they said that it is important to develop a definite full-scale randomized control trial investigating the effects of evening mobilization to treat delirium and improve healthcare outcomes. One more study, it is a systematic review and meta-analysis of the studies, which included the studies that evaluated delirium and A2F bundle, and they found that when compared to standard practice, the A2F bundle interventions resulted in statistically significant reduced risk of incidence of delirium in ICU patients, also significantly reduction in the duration of ICU delirium in studies which followed A2F bundle along with compared to the standard practice. So to conclude, the fundamental prerequisites for a delirium-free ICU is an awake, non-sedated patient, pain-free, comfortable patient whose management follows A2F bundle based on the validated tools and therapies, and along with that incorporating healing environment into the patient care. This healing environment comprises of 3 components. G stands for gaining insight into the patient care, into the patient needs, preferences and habits like music therapy, usage of colors and scents for holistic and personalized care, and providing a holistic and personalized care with home-like aspects, which include the provision of circadian rhythm and adequate sleep hygiene to the ICU patients, and ICU design redefinition to create an environment where the patient feels safe, comfortable with recognizable things in the ICU. And this is the future of delirium-free ICU design, which contains separate hotel corridor for family area and for visitors, and separate medical corridor. This medical, which is for ICU staff, and ICU rooms which are large enough for easy mobilization of the patient, and also there should be acoustic isolation to allow noise control, and separate high-tech ICU equipment which enable the patient to be away from the noisy monitoring equipment in the ICU. This is the future of the delirium-free ICU design that we are waiting for. Thank you.
Very tough to make the delirium-free ICU. Cost is a problem, vascular surgery. Now the Q&A. Both three speakers.
Sir, if I ask a question to Dr. Chakravarti sir. Sir, it is a routine practice to stop ACE-ARB or SGLT2 if the patient is already on those drugs. If he suffers from AK, we stop those drugs. How early can we start these drugs after the recovery of the renal function?
So the data that I showed, actually couple of them have continued during the episode of AKI, or it so happened that they were already on it at the time of discharge. Even in that category, long-term outcomes wise, looks like they did better. But strong data, those who are on ASRs, the recurrent AKI risk is more. So you have to probably stop it the minute patient gets an AKI. Restart it, my understanding is 4 weeks after the episode. And whenever we give a combination of ACE inhibitors, ARBs or SGLT2 inhibitors, which is the standard of care now, we have to tell them any fever more than 100, 101, loose motions, long air travel, vomitings, diarrhea, we want to stop it for 3 days. So I put up, but I didn't have time to go through. The sick day rule is there for many drugs, and it has to be included for these group of drugs also. Just for non-nephrologists, so SGLT2 inhibitors are now standard of care for all CKD, not diabetic alone, non-diabetic also. We start them and titrate so that the protein loss comes down, therefore the long-term progression of CKD slows down. But the same combination works deleteriously or makes them precipitately have a AKI if they are dehydrated. So that is the 4 weeks is a good time.
Sir, one more question. We are hearing these biomarkers for quite some time now, but it's not being percolated into the clinical practice. So do we have any bedside tubular function marker? Because creatinine is always a glomerular function marker, whereas we tend to neglect the tubular function part.
So both NGAL, CCL4, they are all talking about nephrocheck. They are all tubular markers, and they talk of the damage to the tissue. Whereas creatinine and urine output are functional markers. You combine them, and that is the new staging that I have given as 1S, 1AB, 2AB, 3AB. I think one paper I showed, again we didn't have time to discuss, is FDA approving a panel of markers to use bedside. In the sense, you will have to look at something like LFT. You see bilirubin, you see SGOT, SGPT, alkaline phosphatase as a group. I think the renal biomarkers will have a panel. One which will tell you about the location of injury, one which will tell you about the extent of injury, severity of injury. Third is a prognostic marker. So some of them are categorized as location markers, some of them are categorized as prognostic markers, and some of them are categorized as severity markers. If they have sustained the AKI, so if they go up and go down, that means it's a short, it doesn't have any value. If there is a sustained elevation, they predict the outcomes. If I am understanding correctly, if you are asking me, is there anything we can do today bedside? NGAL is available, NephroCheck is available. Our own experiences, both are useful to pick it up early. You pick up early and then do what? I think we go back to the same AK bundle, which is a group of things that you do to prevent further deterioration. That we would do even with or without biomarker. But I think literature-wise, it looks like AKA diagnostics, it's a big area and there is an explosive literature there talking about in different patient cohorts, validation of this biomarker.
Thank you, sir.
If we are starting on ACE inhibitors or ARBs, are they more prone for hyperkalemia, sir? Because that's the main concern, hyperkalemia, sir.
They have to be monitored. Once you start, the first week you reach it and you make sure that they understand that this drug is given to delay, but it can cause a precipitous fall. I think once you monitor on that dose, you will never have a problem. Problem is if they take coconut water a lot, which most, that much of information you have to give them. Salt, coconut water. But I think that is the only thing we have in our armamentarium now to prevent progression, and strong data for combining both SGLT and ACE and ARBs.
So what is the minimum or the above blood pressure which we are comfortable starting on antihypertensive patients who are in ICU requiring dialysis patients? Because the main concern is, because for example, if the patient is having 160 by 90, say there's recovered from hypotension and is going into hypertension, sir. Because once we are starting him on...
So I think as long as they're in the ICU, they look at the mean arterial pressure.
Mean arterial pressure, sir. Because once we are starting on antihypertensive drugs, sir, because the main problem is we are pushing him into suddenly hypotension and further delays the acute kidney injury.
So if somebody had a hypotension, then starts having hypertension, I will not start antihypertensives in a hurry. I would preferably use a very short-acting drug and aim for around 140/90 or 150/90. I don't want it to come below that. It's good to keep a higher pressure. Inside the ICU, I think most of the times you just use for that episode. You don't want it for long term. Once they're outside,
So intravenous formulation is always the better.
short-acting drug which you have a hold on, because they may have high in the morning, but again in the afternoon they may have.
Because it further delays the recovery of the
Because after any oral absorption is out of your hands, it will take its own sweet time to go out. So intravenous short-acting drugs are the best options to manipulate that.
But exactly doing the ventilator strategy differently because of the PCO2 or anything else actually?
So nothing majorly for PCO2. If I am talking only about cardiac arrest, normocapnia is the strategy. But if you are talking about non-cardiac arrest scenarios and you want to control your CO2 for, let's say, for ARDS or this, then you have an ECOR as an option. And we do a hybrid ECOR. We put a pediatric membrane oxygenator on a CRRT machine, and that is how we do it. We still don't have the established ECOR.
It's not evolving, but
I
then your machine.
They're coming up with a newer circuit.
It already has an addition to the CRRT.
It comes with a, you put a neonatal membrane oxygenator in series with the.
They have their own now. We are Indianized. जुगाड़ कर रहे हैं. अभी उनका proper आ रहा है.
That's 1.5 lakh rupees, and what we are using is 25,000 rupees. So the cost difference is too much. I know that's why Gambler is coming up with their version.
Sir, Rashid sir. So, bedside applications of high-dose diuretic when the patient is witnessedly going into an area. Witnessedly, just he was reasonably feeling a few ml of urine output for the last 2 to 3 hours, and patient is in vasopressor support. So we know that in the next 2 hours he is going to become anemic. So at that point of time, like a strong dose of Lasix, practically I have seen that patient is putting out good urine output, despite there may not be good improvement in the creatinine. Maybe coming 2 to 3 days, creatinine seems to be worsening. But if give enough time and the hemodynamics are properly taken care, by day 2 to day 3, the creatinine also settles down despite urine output is already improved. So what's the take on?
You are trying to tell the same concept of furosemide stress test. So you use a bolus dose of diuretic and ensure good output. It may delay your dialysis and sometimes it may even avoid. So my understanding is if the person is fluid replete in the correct compartment, what I mean is in the vascular compartment. Somebody may have a lot of fluid in the tissue but no volume in the intravascular compartment. In those situations, giving a high dose diuretic, we are actually causing more damage. So whatever data was there earlier, diuretics delaying the recovery, is because of that. And coming back, it's an individualized decision. In a particular patient, you feel patient is fluid replete in the intravascular compartment. Giving a bolus dose diuretic and waiting is a good thing. Please don't worry about creatinine the next day. There is a concept now called worsening serum creatinine, WSCR, in the ICU is not equal to AKI for various reasons. The cohort where it is studied very well is cardiac failure. In cardiac failure, when you use diuretics and the serum creatinine bumps up, that cohort of patients do better than in those you give a diuretic and serum creatinine doesn't go up. So keeping that in mind, they call it as worsening serum creatinine rather than AKI. Because when you say AKI, you are actually talking of the damage at the tubular level. So when you give a diuretic in a fluid replete patient, creatinine goes up a little, don't worry.
It's not Dr. Sindhu, it's a paradox. And how do you explain it? The creatinine rising, patient responding.
So if you have decongested the venous system, patient is doing well. Creatinine goes up for various reasons. One of the things is your sodium delivery to the juxtaglomerular apparatus is more. It causes a drop in GFR, what we call as a tubular glomerular feedback. So any diuretic when you use, there can be some increase in serum creatinine.
How is it a response, or you say it is a positive predictive thing?
This is what is seen in large cohort of heart failure patients. It means that you probably have decongested them enough. Taking it further, they have looked at BNP. This is data from Dr. Alan Meisen. He did a lot of work in heart failure. Data, they looked at serum BNP levels and NGAL at the time of discharge. If NGAL was higher, NGAL is a tubular damage marker. That means you have caused some damage by giving. So I am telling you, you have caused decongestion, creatinine has gone up, but there is no AKI. That's a subset. That means NGAL is normal. But if NGAL has gone up, they do badly. So it's rise in creatinine, but not tubular.
To add to this point, when the distal delivery of sodium goes up, the juxtaglomerular senses and then sends a signal to the glomerulus and afferent arteriole constricts. So the filtration pressure drops. So naturally your creatinine goes up. So when the filtration, that's what we are doing by doing these SGLT2 and all. So we are keeping the filtration pressure at a lower level so that the intraglomerular structure won't get damaged. So it is a type of protective thing. If you give a diuretic when the volume is depleted, so as sir is mentioning, but the volume should be depleted. If the volume is depleted, then we end up in problem.
No, but the question which I am asking is, in most of your cardiorenal phenomena, when you say venous congestion, your venous pressures are up, this is causing venous edema or venous back pressure and you give a diuretics. We most of the time see creatinine settling also. So the other side we see is creatinine rising with a dehydration and volume depleted. If my creatinine is rising, is it a time to relook into whether I need to readjust my diuretics or not? Because most of us do it. That's what I'm questioning.
The understanding is fluid replete. If there is I showed you one cartoon where the pressure is so much in the venous system, your filtration pressure has fallen. In that cohort of patients, your diuretic actually should improve. I am talking of patients who are fluid replete, who have not yet dropped their GFR. You use a diuretic, by the mechanism Venu has explained, there is a tubular glomerular feedback, creatinine can go up. But if your NGAL has not gone up, that means you have not caused any damage to the tubule. This cohort does better than those in whom you give the diuretic, but the creatinine doesn't go. And it's large data, it's not few hundreds, thousands.
So with so many filters in the market, sir, so in your experience, what do you think which is the best? Sir? Finances is not the issue for the patients.
So I think you should know why you want to use a filter. You want to remove cytokine, you want to remove endotoxin, you want to remove both, you want to do bilirubin. So they are now custom made. I should mention in COVID time, there's a huge surge, and most of us found that when you use it, the hemodynamics improve. But as of date, there is no data to support mortality benefit using any of these filters in any patient cohorts. So I think you have to decide why you are using it.
Thank you, delirium. Sincerely, I am not really monitoring delirium. How many of ICU specialists are really monitoring delirium, which is only ICU gap score for 30 seconds? Kola, no, round time highest number in 7-star critical care specialist or 5-star hospital.
There in our ICU seat, they just need to round up.
I understand, but we are not able to see. We are asking delirium and we are not able to really do that. I am not blaming. It's only that.
I think the moment you go to your patient, even though you are not doing, you identify some of them are hyperactive, hypoactive delirium. We see substance abuse in many. Right now I have a patient who actually post cardiac surgery, 2 days extubated, re-intubated, CT was suggesting a severe ARDS, there was a debate, ARDS, congestion, all that, smoker. And 2-3 days of ventilation proning, the patient's PF ratios, everything got better. And now the moment you are dropping the relaxant, he is getting aggressive, pulling, and again from FiO to 0.3 to going to 1. It is not uncommon. Then we went deeply dived into it, he was a chain smoker. We needed 2 nicotine patches, just at 21 milligrams, which many of you may be using. 1 was not enough, 2 was not enough, so we kept on increasing that. So what I am saying, substance abuse, ICU delirium, we do see in our rounds. So the moment you see, at least go back and ask whether there is any score at least monitored or not. That will probably make us a habit of it.